So welcome in. Welcome to this. So I thought it would be good to start with sort of why I am interested in this stuff, why I'm here, and why I wanted to sort of help out with this team. Some of you guys I know a little bit. Some of you I don't. I'm local to the area. I've been involved in emergency services, fire and EMS, both here at Del Mar Bethlehem EMS and Del Mar Fire Department for about a dozen years now, just shy of a dozen years. So relative newcomer to the game in terms of first responders. But I saw my first patient in grad school just about 30 years ago. So I've been doing mental health stuff for a lot longer than that. And when I got involved in fire and then EMS, one of the things I kind of noticed is that we're not great in first responder worlds at handling mental health stuff, our own mental health stuff. Either because we're using really old models from the 80s and 90s that are sort of outdated, or we're just not paying attention to the right thing. So I started getting involved in this a little bit just because as someone who's been involved in fire and EMS, I've been to the bad calls, fatal fires, pediatric cardiac arrests, that sort of stuff. Seeing people that I know, if some of you guys know in town, we've had first responder suicides, so I've seen that stuff and really got kind of invested in bringing kind of what we know and what we've learned in my world in psychology the last couple decades into kind of the worlds of first responders, which is how I got kind of involved. But the reason that we're all here, the reason that sort of together is that we know that first responders, all of our first responder groups have elevated rates of behavioral or mental health issues, right? So the ones we're going to really focus on are PTSD. That one has gotten a lot of press in the last few years, in first responder communities. Substance misuse, depression, and then suicidality. Those are kind of the four that I want to cover. We are people that help people for a living. That is what we do. People care a lot. We get into this business because we want to do good and help people out. But when it comes to helping ourselves out and helping our colleagues out, we often don't know how to help, what we should be doing, or where to turn if the person needs kind of a higher level of care. And so that's part of what we want to do tonight, is kind of give you guys some strategies for that. You will not be a mental health expert at the end of this, unless you came into here as a mental health expert. Most of you probably don't want to be mental health experts, right? But this is really about practical, both knowledge and skills, so that by the end of this, sort of my goal is that you'll have really concrete stuff. You could literally walk out this door and have something to do if you needed to, right as we got done. And I broke this into two different parts. First one is just the background. So I think it's important to really talk a little bit about how bad is it as a first responder, really how elevated is our risk. But then not only what is our risk, but why are we at risk? I go to a lot of conferences, and I see this stuff a lot, and I think that one of the things we sort of miss out on is helping explain why it is that first responders, corrections, police, fire, EMS are all at elevated risk. And so I want to kind of contextualize that a little bit in the first part. So how bad is it? Why are we at risk? And then talk about, hopefully, the more optimistic side of this is what can we do about that? How can we reduce our risk, help others out? And I'll talk about individual level stuff, something you can do yourself, for yourself, and then stuff that you can do for peers, and touch on that a little bit. So first part, how bad is it? Why are we at risk? This is the really joyous half of this talk, right? Let's talk about PTSD first, partly because it is the one that's gotten, like I said, the most attention recently. And I hate slides like this. I don't want to spend a ton of time talking about diagnostic criteria and stuff like that, but I think it's helpful to kind of get a sense so we all are on the same page. And PTSD is one of those few psychiatric sort of conditions that has a definite cause. So you have to actually experience yourself or see happening to someone else a traumatic event. And we typically reserve this for pretty traumatic events. This is not someone cut me off in traffic, I got annoyed with them. We'll talk about what they are in just a second. And what we also don't do is we don't diagnose PTSD within the first month after an incident. Why? Because it's really normal to have the symptoms of PTSD, what we would normally think of as PTSD, immediately after an event. So being keyed up, not being able to go to bed, thinking about the event, having a dream about the event. That kind of stuff is absolutely normal, so we don't and will not diagnose PTSD in the first month after an event. We save that diagnosis for someone who's either had that and it doesn't go away, so 3 or 6 months down the road, they're still having those kinds of things. Or there's actually a subset of PTSD that starts with a person feels like they're fine, and then over 3 to 6 months or so, it actually starts to build on them. So that 6 months down the road, they were worse off than they were the day after. That part's a little more rare, but we see both of those. So what we're really looking at is someone who is having these kinds of symptoms down the road, not immediately after an event. And we see these intrusive symptoms. So this is can't stop thinking about it. This is having the nightmares or the dreams about the event. Flashbacks, happen. We have avoidance symptoms. So not going by that that intersection where the car accident happened, something like that. Not wanting to drive by a house or an area where that reminds them of that event. Mood tends to be low. We'll see a lot of depression. We'll talk about that. Cognitive symptoms, again, thinking about that. Irritability happens a lot. And then people get really jumpy. That arousal, really, really hypersensitive to loud sounds and things like that. So that's kind of what PTSD is. I just wanted to put everybody on the same page. The ones we typically see across the fire, corrections, EMS, police are your own death or injury. That's a traumatic event, and that's something that is pretty much built into what we do. We do stuff that gives a pretty high rate of our own injury or serious injury or death. Seeing injury or death in another person, so car accidents, witness an assault on another person, that sort of thing. Again, built into what we do, right? I mean, it's we're part and parcel of what our jobs are. The last one I want to talk about is moral injury, and it's a kind of new. It's associated with PTSD. It's a little bit different. Really got studied looking at people coming back from the Gulf War. And it's basically a person was in an event, witnessed an event where they either did something or didn't stop something that they feel was just deeply morally wrong, ethically wrong, or they were part of something that just violated that sense of right and wrongness. And it doesn't even necessarily have to be a trauma, but there's this sort of violation there. Where we saw it in kind of the first responder communities, particularly, we saw it a lot in EMS mostly, but we see it in other agencies as well, is like the PPE shortage. The agencies don't care about us, they're doing us wrong, and we're putting our lives on the line, and people are walking around and not paying attention to this stuff. And so sometimes you see anger associated with this, and you see a lot of guilt if somebody was involved in something like that, or a lot of regret. I put it under PTSD because we treat it kind of like PTSD, but it's different enough, and it's kind of a rising issue. We feel like we may have missed the boat in a lot of people. They don't exactly have PTSD, but they have something pretty similar that's related to this sort of insult and either I've been done wrong, or I did something wrong, or I didn't stop people that I know doing something wrong. All right. These are the numbers. Most personnel, I love studies that say that not 100% of us have been exposed to a traumatic event. I don't know who they're interviewing, like somebody like the day after they graduated, I guess. So let's say all of us, right? What we do puts us in contact with traumatic events. Somewhere, again, I'm going to try to condense a bunch of studies across multiple types of, corrections, first responders, that sort of thing. Numbers run somewhere around a fifth to a third of us will develop serious symptoms of PTSD across a career. They've done this by using a couple different things. Sometimes we just use questionnaires instead of like sort of really full-blown clinical interviews. They're pretty good, so we're pretty confident in these numbers. So somewhere between, again, a fifth and a third of us will develop at some point those symptoms. So we really are at elevated risk, somewhere between 3 and 4 times the risk of the general population. So this is not made up. We do have a much higher rate of PTSD across, and this is across all of our sort of professions. So that's that we are at elevated risk. I do want to take a minute and talk about why we're at elevated risk, because I don't think we explain that enough. And the idea is that most people in their lives, most US adults will experience, last sort of study I saw said that most of us, just as citizens, will experience 3 traumatic events in our lifetime. Serious traumatic events, major car accidents, watching somebody get really injured, something like that. I've had people tell me, I've had 3 traumatic incidents on a shift, let alone 3 in a lifetime. So the idea is that, let's say you get in a bad car accident, you got time, you talk it over with your family, you heal up, you kind of process it, you work through it, whatever language you want to use. And then 10 years later, something else happens, and then you kind of work through that, and then, another X number of years later, you do that. the idea, that we seem to face is we see an incident, we're involved in an incident, and then there's another one, and then there's another one. And it's kind of like, I think the metaphor I use is it's sort of like, you break your leg, you put a cast on it, you don't walk on it for 6-8 weeks, you heal up, you're good to go. What we end up doing is running on a broken leg, and it just gets worse and worse and worse. And that's what we really see, is this sort of repeated insults without enough time to really stop and think through it, work through it, talk it over with our colleagues, our friends, whatever, or just let time pass. That sometimes time passing is what does it. So we don't have time, and so that's where we think the problem comes, is it just getting those repeated insults time and time again without enough time in between them to kind of work through it. PTSD is associated with all the bad stuff we'll talk about tonight. It's associated with everything else. So higher levels of depression, very, very common, levels of anxiety, higher levels of substance use, particularly alcohol abuse, lower overall quality of life, higher levels of suicidality. So I put this one first because everything else I'm going to talk about is kind of, PTSD will hit on these, right? It tends to be chronic without treatment, but as we'll see, there are treatments for it. So substance use. There's a ton of definitions out there about addiction and dependence versus abuse, and I don't want to mess around with all of that. There's a lot of people disagree about exactly what word we should use to talk about this. What we're really talking about is a level of substance use that interferes with a person's life, right? Miss work, get in fights with their family, something like that, starting to interfere with other areas. Frankly, most of the work that's been done has been done on alcohol. We haven't seen a lot of work on marijuana, especially since it's been, even in the states where it's been legal for a while, we haven't really seen a lot of studies on rates and use of problematic marijuana use in, corrections and first responders. So most of the stuff is what I'm going to talk about is mostly alcohol. The numbers, again, depending on the study you look at, depending on how they define misuse, running about 2 to 4 times the rate of substance use, problematic substance use compared to the general population. So again, we kind of somewhere between double and 4 times our rates. And why? Well, first of all, alcohol is a coping response, right? People use alcohol to deal with negative life events, including traumatic events, right? So the fact that we see this stuff does put us at elevated risk for substance use. And then what we say is it's also, in a lot of, especially sort of historically, substance use was encouraged, not just accepted, but that's what you do. And, you get off shift, you go have a couple of drinks, and that's what you kind of do. You celebrate, you commiserate, you do whatever. Alcohol is a part of it. So basically, you get in a situation where if someone is vulnerable to substance dependence, this is an environment where that can come out. It's not that it sort of directly causes it so much as it facilitates it if a person's going to have an issue with it, right? And so that's what we see with substance use. Again, mostly alcohol. Depression. When I say the word depression or people say the word depression, we mostly think, oh, that person's sad all the time, and low mood is one of the main symptoms, but we also see a lot of irritability. So it's, and one of the ones that is kind of flies under the radar a lot is this loss of interest and pleasure. It's called anhedonia, which just means loss of interest and pleasure in Latin, but it makes you sound cooler if you say it in Latin. People are like, I don't want to do that anymore. It doesn't do it for me. I used to like to go, play softball. I could take it or leave it, right? That is actually a symptom of depression. Changes in appetite and sleep, either up or down, eating more, sleeping more or less, things like that. A lot of fatigue. The real highlight is also feelings of worthlessness and guilt. Person feels like they're a terrible human being. They feel very guilty about things. That's also kind of one of those keys that differentiates it from just being tired, let's say. And then higher levels of suicidality as well. Rates of depression. Depending, again, if you look kind of across disciplines, we run somewhere around 7 to 12%, which is frankly maybe a little bit elevated above the general population, but not as bad as, let's say, our PTSD numbers and our substance use numbers. So this is one area where it's not horrible. We're basically on par, maybe a little bit worse than the general population, even though we have higher rates of PTSD and substance use. So, it's still a concern because it's associated with lower quality of life, it's suicidality and stuff like that, but this is one area we don't have to worry quite as much. Why are we at risk? Well, first of all, because we have these other risk factors, right? PTSD, substance use. And I'm going to talk in particular, it seems to be the subset of people that cope with stress by withdrawal and avoidance. I don't feel good, so I'll talk more about this, but I don't feel good, so I'm not going to hang out with my friends. And it starts kind of a downward spiral. And that seems to be the pattern. In a subset of people, that seems to be a pattern how they cope with things. And that tends to be the people that are more likely to develop depression. I don't know that that's a pattern we see any more in kind of this area, so that's why we may not be at higher risk. But let's talk about suicide, one I'm going to spend a little bit of time on. Again, depending on the study you look at, depending on how the population, depending on how they ask the question, we're running anywhere from 4 to 10 times higher than the general population risk of suicide. Upwards of some studies have shown that a third of their responders in the survey had suicidal thoughts, not necessarily attempts or plans, but suicidal thoughts. So pretty significant. And this is in the context of the fact that suicide is, across the lifespan, the 10th leading cause of death. It's one of our few leading causes of death that's getting worse across the board. So you put that where this is a true sort of public health crisis, suicide is in general. And we're significantly higher rates of suicide compared to an already bad setup and sort of culturally. And it really has gotten worse over the last 10, 20 years. In every place we've looked, rates of suicide, death by suicide, outstrip line of duty deaths. We've seen this definitely in police. Police have actually done the best job of collecting this kind of data. We see it a little bit in fire. We see it a little bit in EMS. They've just not been as thorough at collecting the data. There's been a couple of studies, some of them out of Canada and corrections, that have shown this. But you could argue that if a person, a suicide related to on-the-job stuff should be a line of duty death. And I'm not going to get into that. So that's you could make that case. I think that you make a good case for that. I'm saying that like that death separate from the other things that we normally call line of duty deaths, right? That our rates of suicide are outstripping those other deaths. So this is really, again, a significant problem. And now I want to spend a minute talking about why we're at risk. Because again, I think that probably doesn't surprise a lot of people. We talk about this stuff a lot, but I really kind of want to talk about why. And I'm gonna bring in a theory. This is the college professor side of me starting to talk, get a little theoretical. A guy named Thomas Joyner is a psychologist, developed a theory. It's called the interpersonal theory of suicide. It's actually been studied some in first responder communities. So it's got a little bit of, shown some validity in our it's been done in fire. They've looked at it in fire, EMS, and police, and it's sort of an active area of research. And the theory says you've got to have two things. You've got to have two things for suicidality to happen. The person's got to want to die, which might seem obvious, right? But they have to have that desire for death. And they have to have the capacity to actually act on that desire, right? And so actually there's a lot of people out there, and as a psychologist, I see these people, they could have high rates of suicidal thoughts for years and never act on them because they cannot bring themselves to follow through on that, right? There's somebody we worry about, but they are not the high suicide risk, right? So just because a person has some thoughts about suicide doesn't mean that they're going to act on them. On the other hand, you've got people who might have the potential capacity to do it. Their life is okay. There's no reason, right? So they don't have that desire. So it's that overlap, a person that really wants to do it and could do it, those are the really high risk people that we really worry about. And so you need both of those things to really be high risk. Why? So cross-culturally, any place we've ever really looked, there seems to be maybe hardwired into us this natural reluctance for suicide, to end your own life, right? Self-preservation kind of idea, right? But what we now understand, or what we think happens, is that over time, a person's repeated exposure to suffering, pain, death, wears away that natural reluctance, basically, right? So that you've got that's where the capacity comes from, right? So it's really the wearing away of this kind of natural reluctance. And let's stop for a second. Who, by the nature of what they do for a living, is exposed to pain, suffering, and death? Like that's us, right? That's what we do. So this is why, this sort of slide I hope starts to explain with this theory, this is why we're at higher risk. Any place where you see someone who's either their job or their lifestyle exposes them to high rates of violence, high rates of seeing other people getting hurt themselves, you're likely to see higher rates of suicide, right? And it tracks just like you would expect. So first responders, corrections, higher rates of suicide, right? ER docs, ER nurses compared to private practice, family practice docs. Right? My family practice doc works in a really nice, cushy office, right? He probably sees sick people, but not the same way an ER doc sees sick people, right? Really high rates of suicide in veterinarians, right? Why? They kill their patients. right? They euthanize them. So they're exposed to death even at a level that, your average, hopefully your average, human doctor is not exposed to. And, people, homeless folks who are living on the street, higher risk of dangerous stuff, higher risk of suicide. So this tends to track like we would expect. Anybody who does this, combat vets versus non-combat vets, right? You see differences. That's sort of the key here. And the other part that is really important is that once a person develops this capacity, once that natural sort of reluctance wears away, we don't know how to get it back. As far as we can tell, and there's some people doing research on this now, but we have not been successful in getting a person to reverse that capacity, right? Where we really have to work is on the desire, right? And no one told me this. I went to both EMT school and Firefighter 1. No one told me, hey, by the way, when you do this, being involved in this work is going to make you have a lifetime higher risk for suicide. And it is lifetime, right? If it wasn't lifetime, as soon as people retired, we see suicide rates drop, right? Because they go retire to Florida, everything is great, right? Go live on the beach and hang out. But what we see that doesn't happen, right? We see suicide rates still stay high even after a person has retired, right? It's why? It's because the capacity is still there. And the idea is that sort of suicide is this relief from pain, right? That a person gets involved in either physical or emotional pain, and it becomes unbearable. They don't see any other way out, and they just want that pain to go away, right? One of the things, and that I think we've made a mistake, and I see this again, because I spend more time in fire and EMS side of things, I see this. We spend a lot of time talking about bad calls, bad events, critical incidents. We activate critical incident teams and things like that. And I'm not saying that's wrong, but what we find is if you actually ask people who have made a suicide attempt and survive, and you can interview them, it is not critical incidents that are what causes this to happen. What happens is those critical incidents have set the stage, right? That's what's built your capacity over the years. Then what you have is normal life stuff, going through divorce, financial difficulties, other life stressors that would make a person be upset because that capacity is there. That's what triggers that suicidal sort of crisis, which can last for a relatively short period of time. So again, it's not that critical incidents are nothing. They really are, and they do set the stage, but they're not really the driver like I think we've talked about them being the driver for suicidality, at least in most cases. Right? It's the normal everyday ups and downs stresses of life that do it to us. We just happen to set ourselves up by what we do to be at risk for that, for suicide. Other stuff that just is risk factors that are relevant, I think, to what we do. Shift work, particularly shift work because of what it does to sleep deprivation. And we'll talk a little bit more about that in a minute. But I could spend an entire hour talking about how bad sleep deprivation is for us. But things like low pay, financial stress, just normal life stuff, right? Relationship stress, family stress, loss, whether particularly like loss of somebody retiring even, like a mentor or somebody you're close to, somebody moving away. Those things are just associated with kind of higher levels of mental health issues. One of the take-home things, hopefully, I've started to sort of get into is that I still see a little bit of this when I look at like social media around first responder communities and things like that. I see people talking still a little bit about, well, if you knew what the job was, if you didn't want to see those things, you shouldn't have taken the job. Still see that a little bit, but hopefully we're starting to move away from that into this idea that these are not a sign of weakness. Right? A person is not weak any more than you're weak for stepping off a curb the wrong way and breaking an ankle, right? Instead, I think we need to start thinking about these as an occupational hazard. It is guaranteed, given what we do, that a certain percentage of us are going to end up having these issues. There is no way around it. Right? I say this. I didn't get to go to this talk, but I was at a conference, and there was a talk of like how to eliminate PTSD in your fire agency. I'm like, that is absolutely the dumbest thing I've heard. We can minimize it, but we're never going to stop this stuff. Right? It is built into what we do. And so I think we need to own up to that and start planning for it. Like one of the reasons we're doing this is we're going to start planning for this stuff because we're not going to make it go away. We want to spend a lot of effort trying to minimize it, but even when we minimize it, at the end of this, there's going to be people who are going to have these issues. And we need to figure out what we're going to do about it ahead of time and plan for that and plan to how do we minimize it and then how do we actually help somebody where all of our other plans have not worked. Right. So that was the exciting, like that's the horrible part of this. Like that's like the buzzkill. Like, oh great, it sucks to be, what we do. Right. These are all the risks. I want to spend hopefully at least as much time, maybe even a little more time, talking about what we do about it, because there really is a lot we can do about it. I don't want it to feel like, oh great, I just said, this is a part of what we do. There really are some things we can do to minimize this stuff, and that's what I want to spend the rest of this talking about. I will acknowledge at the beginning of this, some of the stuff that we're going to talk about, some of these stressors are systemic, right? Low pay. Shift work, I can't fix that. I don't know who's going to fix it, but it's going to take, that's a pretty slow ship to turn around, even if we decide we're going to triple everybody's pay. That would be great. I don't know how we're going to do that. But, I don't have that magic wand, and none of us do. So I want to focus on stuff that is not kind of like theoretical stuff that, I'd love it if we all had more money and didn't have to work shift work like we do, that we could, again, walk out of here at the end of this and have some ideas. Start with focus on yourself. Just because I think that's an easy place to start. Individual things you can do to focus on lowering your risk for some of these things. Start with physical protective factors, partly because physical health is a foundation. You cannot out-psychologize biology, right? Your biology is going to win eventually. You can't, you haven't been sleeping for 36 hours. I got nothing that's going to, your biology will win and you will fall asleep. So, and you will have the effects of that fatigue. So I do want to talk about these physical protectors first, because they really are that sort of foundation of this whole thing. So I'm going to talk about sleep first. As I said, I could spend an entire hour and a half talking about sleep, the importance of sleep. The stuff that's most relevant for us is we know, for instance, that sleep deprivation directly increases the risk of developing PTSD. So they did a really interesting study where they took people who had been through a traumatic event, and they asked them, in the 2 weeks before that traumatic event, how was your sleep? And the people who just naturally, again, they didn't plan this traumatic event, it happened to them. The people who had, in the 2 weeks before that traumatic event, had reported they had adequate sleep and they felt well rested, ended up developing had significantly lower rates of developing PTSD than individuals who reported they were sleep deprived, right? Some of you right now are saying, oh no. Right, because what do? And we do shift work, right? We're sleep deprived, and then we go on that shift and have a traumatic event. We are setting ourselves up for failure. Again, one of the reasons why I think we have elevated risk for PTSD is that it's kind of connected to what we're doing to our physical organisms along the way, right? It's also associated with, directly associated with suicide. So they've actually taken people, these are mostly people who are depressed, and asked them about their sleep, and then ask them about their level of suicidal thoughts. And the same individuals, when they're well rested, have lower rates of suicidal thoughts than they do when they are tired and fatigued. So there's really a direct connection between those two things. So sleep the most relevant to what we've already talked about, sleep deprivation directly affects two of the things that are most, that we've been talking about is PTSD and suicidality. On the other hand, people who report getting good sleep, it's a protective factor. Right? We know that regular sleep and low levels of fatigue make it easier to handle all those ups and downs of life. Right? Depression levels are lower. You're able to kind of to think better and think through some of those events. So that's a real important protective factor, which is why I want to talk about it first. I think of this as like the keystone habit. Like this is the one I'll say a couple more times. If you have to focus on one thing physically, take care of, it's to take care of make sure you're focused on sleep. Other reasons, not on here, just it makes you worse at your job. It also may increase risk of cancer. It's a bunch of things that sleep deprivation, like I said, I could go on for an hour on this. But for us, these are the ones I really wanted to focus on. Solutions. Like I said, this is the keystone habit. If you, let's say you get off shift and you're tired, but you got, your buddies are they're like, come on over, we're having a barbecue, do something. I would say focus on sleep first. Social support and social networking, as I'll say, is really important. But if you had to pick the two and you're really tired, take care of the tired first, and then we'll work on the other stuff. I know if you guys are working shifts, I'm part of the problem. When I volunteer here at this agency, I work midnight to 6, and I go to work sometimes at 8:30 the next morning. So I am part of the problem, but what I do is I try to work around that, and the day after I do one of those shifts, I will try to minimize what I do that day, and I'll try to see if I can get myself a nap in. The two naps that you should really care about the most, I don't know if anybody's ever seen this work. when you go to sleep, you start in what they call stage 1 sleep, which is very light sleep, and then you move into stage 2, and then you move into stage 3 and stage 4. 3 and 4 are deep sleep, and then you go into REM sleep, which is when you dream. And if you take a 20-minute nap, you start in stage 1, most people just starting to dip into stage 2, you wake up, so you get it actually makes you feel a little rejuvenated, a little more alert, but it's not enough to get that sleep hangover that you get when you like wake up and you don't know what day it is and it's like you're groggy for 20 minutes. That's normally when someone has woken up in that stage 3, stage 4, like that deeper sleep. Just makes it harder to wake up. Something I've really seen, I've tried this and it works, a coffee nap. Anybody hear coffee nap? You hear about this? Yeah, Nappuccino, right? You basically slam a cup of coffee and then take a 20-minute nap. Caffeine takes about 30 minutes to metabolize. So just as the coffee's kicking in, you wake up from that nap and the combination of 20 minutes of kind of and a little bit of caffeine will give you alertness and decrease fatigue and stuff like that. It's not a magic pill, but it works pretty well. I like it. The other one is a 90-minute nap, and that's because it's a sleep cycle. You can argue that 90 minutes is more than a nap. Maybe that's a mini sleep. I don't know how you want to define it, but at the end of 90 minutes, you're naturally in that shallow where you go 1, 2, 3 REM, 2, 3, 4 REM, 2, 3, 4 REM, and those other sleep cycles for the night or whenever you're sleeping. And so you back up in 2 at about 90 minutes. And so when you wake up, you don't have that groggy, like 20 minutes to kind of wake up feeling. There's nothing wrong with a 45-minute nap, nothing wrong with a 60-minute nap. It's just harder at the end to wake up. And so that's why they sort of recommend like 90 minutes. Now, I know this may not be possible given what you do and given what your job is, but again, it's trying to be creative in ways to sort of prioritize this over other stuff. You may have heard that you can't make up for sleep deprivation. It's actually not true. You can kind of make up for sleep deprivation, not 100%, but if you've been sleep deprived, getting some extra sleep can actually have some benefit. And we start to see some of those benefits in as little as 1 sleep session. So, it doesn't take, I've been sleep deprived for the last 3 months, I need 3 months to get it back. You actually can get some of that stuff back and get some of that alertness and decrease those effects pretty quickly. Like I said, as little as 1 really nice, catching up on sleep can actually make an impact. Diet. There is no one best diet. If you go right now to the closest bookstore, which is right over there, you can find really convincing books telling you to become a vegan, and really convincing books telling you to eat nothing but bacon, right? Everything in between. From keto and paleo to Atkins to Mediterranean diets to vegetarian to vegan to whatever, and they've all got pretty convincing evidence, right? So what we've decided is there is no one real diet that is the best diet in terms of overall health. But what we do know is if there's one thing that these people agree on, and they disagree on everything, but they agree that most of us should stop eating as much junk food as we do, as much processed food as we do. We should probably get more fruits and vegetables, and we should probably try to get a little more variety in our food. That's all I got. That's all I can really say with any credibility. But what we do know is that we tend to overuse fast food. Because why? We're tired. It's effortful to have to cook. So why not just run by and grab something, either for breakfast or for dinner or whatever? It's really easy to sort of rely on the processed stuff. I've seen a lot of people start to rely on some of those meal plans and things like that will provide better food, sort of like less processed food for you. But that's really all I got is we should just, if at all possible, minimize the processed, fast foody kind of stuff and try to get more fruits and vegetables. That's so earth-shattering. Nobody's ever heard that before. I feel so, really? Fruits and vegetables? Nobody's told me that. Physical activity. I don't know. In U.S. culture, we tend to use athletes as the model for physical activity, for health. And it's a horrible model, right? It's a great model for being athletic. It's a horrible model for health, right? So I'm going to talk about physical activity for health. I'm not even really going to talk about exercise, right? I was an athlete. I was an athlete through college. I still do some stuff. But when I do that stuff, it's for reasons other than pure physical health. Okay, so what do we know about physical health? Is that the most benefit anybody gets from being physically active is to go from being sedentary to doing about 30 minutes of moderate activity a day, most days of the week, right? What is moderate activity? I love this definition. Walking as if you're late to an appointment. Right? Just you got to put a little oomph into it, right? And the most interesting thing to me is it doesn't have to be all at once. So they've done studies where 2 15-minute walks on a treadmill will have health benefits equal to 30 minutes. Now, are you going to be able to run a marathon? No. You can have a body weight bench press? No. Right? Are you going to be healthier? Yes. If you like doing that other stuff, and a lot of us do, if you like working out, if you like playing on a volleyball league or something like that, do that stuff. But a lot of people think that because they can't do that stuff, I don't have an hour and a half to go work out, that they just don't do anything. And what we're saying is that, like, do all the fun stuff you want to do, but call that leisure, recreation. You're competitive, you want to do those kinds of things. But for health, it's actually really pretty easy to reach those levels if you give it a little bit of effort. Again, most people can find 15 minutes. Some of you may be getting, especially if you're doing a lot of walking, what we find is like floor nurses and other jobs, they actually get like miles of walking every day. They actually get it in their jobs. So if you're doing a lot of walking, you may actually be reaching that already without even knowing it. The problem is we don't call it. We think we can because we're not wearing spandex or special shoes, that it doesn't count. It absolutely counts towards health. So again, you like doing stuff, you want to be physically active, you want to run a marathon, you want to lift weights, you want to play on a whatever league, that is great. It just don't think that you have to in order to maximize health, right? And again, we see pretty quick benefits, right? So I was involved in a study with Albany Med where we took people who were kind of on the edge of type 2 diabetes, were already taking some medications for that, and within a couple of weeks of starting to walk regularly, they saw a drop in their medication levels, like really quickly. And so again, you don't have to be in awesome shape to start to see those health benefits. So it's a pretty low dose, and it happens pretty quickly. All right, so that's the physical stuff. I mean, sleep, diet, exercise, right? Nothing that shocks anybody. We always talk about this stuff, but I wanted to give you at least a few practical things that way. Let's talk about the mental side of things. And I mentioned this. So one of the things that we see that turns out to be a really big risk factor is that for some people, and again, this is not kind of first responder correction specific, so a subset of people, when they get under stress, respond to that stress by withdrawing. Like, again, why? It makes sense. I don't feel good. I feel stressed, right? So, I don't do the stuff I would normally do. I don't hang out. I don't go to the gym. Maybe I don't eat right. I start pulling back and withdrawing. But then I didn't do it. I didn't hang out with my friends. So now I feel a little bit worse. And then that stress is still there. I feel a little bit worse. And so we see this downward spiral that starts with this pattern of pulling back and getting out of your life. And so that's the pattern that we really want to reverse. And we're starting to really see this pretty consistently as the pattern that is associated with developing particularly depression, but also levels of anxiety and things like that. So what seems to help the most? Social support. Like, there's probably fewer than half a dozen things in psychology that are reliable. And one of the reliable things is social support is a good thing. Having social networks, having some friendships, is good as a protective factor for depression, for anxiety, for PTSD, for all the things we've talked about, suicidality. Having context both on and off the job seem to be pretty important. On the job context, social networking and friendships important. Why? Because there's some stuff you don't want to tell your family and other friends, right? Because they get that wide-eyed look when you start talking about what happened today, right? And there's sometimes they'll understand what you're saying and they'll kind of get the context of what you're doing. On the other hand, if you only have friends on the job, you sometimes start to get a really sort of skewed view of reality. So sometimes it's nice to have that touchstone of that accountant neighbor next door, you have the barbecue with, and who can, sort of provide a slightly different view of what the world is like. And so having both seems to be helpful. And there's also different classes of social support, right? There's casual acquaintances, people who, maybe they're great to watch a game with, hang out with a little bit, but you don't want to, they're not somebody who you would disclose, like, you're having relationship issues with, right? They're fun, and and it's good to have those people, right? You don't always have to have a deep conversation. You might just want to go hang out and take your mind off of things. Good to have those folks, but it is also nice to have at least a couple people that you feel like you really could talk about that stuff with. A marital issue, relationship issue, financial stuff, or just, having a rough time. It's helpful to have some of those people as well. I'm going to say this a few times because this is one thing that's really, we're really seeing a lot in research and sort of mental health, is that you would think that me just talking about this stuff, people go, oh, that makes a lot of sense, I'll go do that. It turns out that when people are under stress, the first thing that goes is the stuff that's the most likely to help them, right? So you have to actually deliberately schedule this stuff in your week. It doesn't have to be every day. But you have to sort of say, like, on Saturday, I'm going to do this thing. When I get off of, Monday evening, we're going to go do that. I'm going to spend some time with my family. We're going to go, do this thing. I'm going to go watch a movie, whatever it is. Just saying I'm going to do it when I get around to it, because what happens? We get tired, we get busy, we got to go to the grocery store, we got to do all that other kind of low-level stuff that takes time away. Not that you don't do that stuff, but you really got to prioritize this stuff. And what we know about this is that you can have an almost immediate benefit in mental health with social support. You go start hanging out with somebody 5-10 minutes, and you start to feel better. It takes your mind off of things, whatever. This is not like you don't need a lot of this stuff. You just need to do it. Right? So we're really looking at something that has can have a pretty profound and pretty immediate benefit whenever you do it. There's another kind of intervention. It's called behavioral activation, and it's a treatment for depression. It's been particularly in kind of our world, it's been shown to be effective in firefighters, but it's a pretty well-established treatment for depression right now. And it says that basically you want to spend your time doing this. Spend as much time as you can finding things that give you a sense of positive emotion, happiness, fun, joy, fun times, if you will, right? And then other things in your life that may not necessarily be fun, but they give you a sense of achievement. Like, I did that. That was kind of hard. That was effortful. I can feel proud that I did that kind of thing. And then also it's just stuff that's important to you. It may not be important to me. It doesn't have to be important to me as long as it's important to you. So that if you try to deliberately put things in your life that give you a sense of good positive emotion, like a meaning and achievement, those are the people that show it's a huge buffer for depression, anxiety, things like that. And so again, there's an entire intervention devoted to this. It's really not complicated. It's not always easy, but it's very, very simple in that sense. Right? But what do? We tell people to schedule these things, just like I said with the other stuff, with social support, right? Make sure you spend some time every week scheduling in some activities that are either fun or give you a sense of achievement. Or sometimes it's both, right? But sometimes I would say, like, studying for an exam is not fun for most people, but they like getting a good grade. Like, say, I did that. That was hard. I studied and I got a good grade. Like, that's an example most of us know. This is more about achievement than fun. If it happens to be fun, that's also awesome. Sometimes, hanging out with somebody in their backyard, again, barbecuing or something is not particularly deeply meaningful, but it's just fun, right? And so you want a mix of those things. Again, immediate and lasting effect on mood and stress, right? Really, really powerful. This as an intervention for depression is as powerful as anything we've ever developed in psychology. There's other stuff that works well, but this works really, really well. It's something that I do as my job as a psychologist. I use this one a lot. And again, it almost doesn't feel like you're doing, it's not like therapy. It's basically helping people structure their lives and put in other activities. Again, scheduling is key. What I tell people to do is take 5-10 minutes at the end of your week, beginning of your week, whatever seems to work, and just say, okay, what am I going to do this week? Have I got anything scheduled that's fun, that's meaningful, whatever? Maybe I got my softball league on Wednesday night, whatever. I'm going to the gym. I'm going to hang out with my family on Saturday. And then the next week, look back. Did I do those things? Did they actually work? Did they make me feel better? If so, can I do them again? Can I try some other stuff? So if you kind of put in, but again, you got to plan it. And then I always like to tell people to do the next week, do a check back. Did it actually work? Did I actually feel better when I did that stuff? But again, 5-10 minutes of planning can make a huge difference in actually being able to put these things in your life. All right, so that's individual level stuff you can do for yourself. I do want to talk a little bit about what we do for kind of for helping each other out. Right? If there's something that came out of 9/11, I like so that if you see something, say something, as a model of how to do peer support. You got to see something and you got to say something. I'm going to cover both of those. So to notice, you got to see something, right? To be able to say something to your peers, you got to notice it. Right? So one of the things I will say is because you're here, because you're watching this, I want to say your job is now to kind of notice when the people around you, the people you work with, people in your life in general, are off their game. They don't seem like themselves. Particularly we look at patterns of like irritability and withdrawal. They're not hanging out anymore. They're not doing stuff. You got to notice that stuff, right? And then you got to say something, right? There's this tendency, well, somebody else will notice it. Somebody else will say something to them. And what we want to do is empower people to say, like, there's nothing wrong with going, hey, you doing okay? Like, you don't seem like yourself. You seem like you're a little bit off. But you got to ask that question and say, are you all right? Maybe overwhelmingly, they're like, yeah, I'm fine. I'm just tired or something. But there might be that percentage of time when somebody really is struggling. And this is where we want to sort of make that connection. Why? Because just making that connection is important. right? What we see is people, particularly if they're in crisis, feel like nobody cares about them, right? There's a lot of isolation involved. And you just walking up and going, hey, are you all right? In and of itself, it's therapeutic. Like, it's helpful. And people say that, like, wow, that person really noticed. They care. I am not alone in the world. There are people out there that are kind of noticing me, right? And so just that little intervention saying, hey, you all right? Even if it doesn't turn into a longer conversation, can be something really meaningful to that person. Right? I'm not here talking about like peer support. There are some structured peer support, with, but just talking with each other, sitting around and chatting, is what humans have been doing as long as humans have been humans, right? Sitting around the fire and kind of talking about the day or talking about what's bothering them. And so this is just an informal thing. The overwhelming majority of peer support kind of stuff is informal stuff. You don't have to have any formal process or procedure. You have to just notice that someone else is struggling a little bit and go like, hey, you all right? And if someone says, yeah, well, I'm having some issues with my spouse, you're like, hey, I've had that too, or I'm divorced, and I can like talk to you about that, or I know so-and-so also had that issue. That's how we as humans interact. Just help each other out, just casual conversations. If you've got an agency with a formal peer support team, great. Either because you've got something in place that can help out with that, or the people on that peer support team also tend to have the skills and training to be able to sort of help talk. But you don't need any special training to do this. Most human beings can interact with other human beings to say like, hey, how's it going? You don't seem like you're yourself. You seem a little distant. Are you all right? Those kinds of just little quick verbalizations can make a huge difference. I will say that peer support doesn't have to be peer support. Like, it could be larger social support, right? So it doesn't have to be, it could be, that this person, has a good social network, so you probably need to go talk to them. Or you can get social support yourself from friends, family members, clergy, anybody, really. But the idea is that there should be somebody that you feel like you can talk to, or you feel like you can talk to those people and say, hey, are you okay? Right, kind of this two-way street. Again, what I want you guys to do is pay attention to changes from this norm, right? So the things we typically see, the two patterns that show up time and time again are patterns of increased irritability, patterns of increased withdrawal. Those are the two kind of red flags, but any kind of change from the norm, a person just seems off, right? Especially if you spend a lot of time around coworkers and you know them pretty well. You know when they're, something's bothering them, right? And we do want to encourage people and really kind of empower people to be able to say, just walk up and go, hey, you're all right. Just ask that simple question to start that process. Some of you guys might be really good at this, like you've done this already, you're kind of naturally good at this. I think every agency has people that are like the good people at this. You may be really horrible at this. And if you're horrible at this, I would actually suggest you just take a minute and practice. Like, what would I say? Like, have almost like a pre-canned, statement that you're like, hey, you don't seem, are you okay? Kind of just practice a little bit. Because what we've seen, or what I've seen, and I know from what other people have told me, is that the hardest part to get people to do when we do these trainings is to get them to actually say the words. Everybody's like, I got this, I'm doing this. And you're like, let's try it. Like, and they can't make themselves do it. And so especially if you feel like you are not great at this, and just in your head, take a couple minutes. It's like, how would I say that? Because in that kind of slightly awkward, maybe a little bit, you're maybe a little bit, kind of keyed up yourself a little bit, asking this kind of question. You don't know how the person's going to take it. You might want to rely on kind of just something you've already pre-thought. I'm a big fan of kind of the pre-plan. Just do a little bit of a pre-plan, say, this is what I got, this is what I'm going to say, so that that you don't have to go in there and stumble for the right words. Just, again, that caring attention, which I like that phrase, just your caring attention is helpful. Letting a person know that you cared enough, that you noticed about them, and you cared enough to ask them about themselves is helpful. Right? It means more than you know to a person who is in the middle of kind of a real sort of crisis or particularly stressed time. Even if they don't necessarily want your help, you as that individual, the fact that you said something is meaningful to them, right? So these simple statements, just hey, I'm hope you're doing better. If there's anything I can do, let me know. All those kinds of things can really make a big difference to somebody. Even if they don't want to use them in that moment, they might come back, or they might say, at least I got somebody on my side, is the kind of thing they're thinking, right? What we're really looking at here is also kind of changing, like I said, this department culture, right? So that it's okay for everybody to ask anybody else, hey, you doing all right? And it's not weird, it's not awkward, just because it's one of those things that you say. And I don't mean in kind of just like, hey, how's it going kind of way, but that you say it, you mean it, but that it's pretty normal to do that, right? That's kind of one of the hopes, is that across the board we get people that feel comfortable and have departments that feel comfortable with that kind of stuff happening. All right, so talked talked about helping yourself, talked about some peer support. I want to talk a little bit about the next level of care, kind of the higher level of care, if necessary. Because, as I've said, we're always at elevated risk, right? Lifetime elevated risk. There are times when, despite our best efforts, you could be an awesome peer supporter, you could be exercising right and eating right and sleeping, and still, for whatever reason, you or somebody else in the agency, in the department, could end up, that stuff doesn't work. And they end up developing, their mood goes down, they have depression, they end up getting PTSD after an event, they become suicidal. This is going to happen. It is happening in most agencies, right? We just don't talk about it that much, right? And so what we want to do is sort of say, like, okay, if everything else fails, we've done our best. We've given our best peer support. That person is doing the individual stuff. The agency is supportive. Everything is there, but it still happens. It's going to happen. It's happening now. Well, what do we do about it? Again, I think we need to have a plan, right? The thing I just want to say, I'm going to fully put my mental health professional hat on here, is we have really effective treatments for mental health issues, right? There are really effective treatments for depression. There are really effective treatments for anxiety. There are really effective treatments for PTSD. One of the things that I see when I kind of look at social media is people tend to talk about PTSD like it's this lifelong thing that you got it and you're never going to be able to get over it. And I can tell you that is not true. We have really effective non-medication based treatments for PTSD that really work. I'll talk about some of them in a minute. But they don't start working until the person starts getting help. Right? And so the longer that person waits, the longer they suffer. And so by getting people sooner rather than later into that higher level of care, the better. Right? And we are not, as first responders, as corrections as officers, whatever, we are not the final level of care sometimes. Sometimes we are. Sometimes a talk will be enough. But there are times when it's not going to be enough. We've got to know what to do and when to take it and where to take that higher level of care. All right, so when do we kind of move up that level? And I'm going to give you just some rules of thumb. Right? There's no hard and fast rules, but we know that in most cases, a lot of life stressors, even people in treatment, will start to see improvements within about 8 weeks or so. Right? So if a person has been trying everything, you've been trying stuff, you've been helping them out, you've been talking to them, people have been talking to you, and it's been a couple months and it's still not any better, maybe that's because the problem is chronic. Maybe it's a financial situation. Maybe it's a relationship situation that's not an easy fix. But if it's been a couple of months and they've tried everything else and nothing is working, I would say that's time to start to think about raising that level of care up and going somewhere else. Because again, we would expect that if it was going to work, it probably would start to work at least within those first couple of months. Right? So if you haven't seen any change at all, it's time to try something different. If a person is now we're starting to move into kind of the red flags. So if a person is having trouble functioning, you see them making mistakes on the job. They're forgetting stuff. They're not doing what they're supposed to do. You hear about stuff that's happening at home and they're just not able to function as well. That's kind of a red flag. And we've got to kind of move that up the ladder of care, And then finally, obviously, the reddest of the red flags, the most serious is a person, you feel like that person really is a danger to themselves or others. The sort of direct worry about suicidality, homicidality. That's clearly a time to step that up to the next level of care. Where to go? Superiors, right? Now, I know that some people say, there's a true worry in a lot of agencies. If I go up the chain, then I'm going to get pulled and bad things can happen in my career. On the other hand, sometimes, and I'm not telling you what to do, but I'm saying that there are times when superiors can get a personal leave. They can do things. They can connect you with resources. So people have to play that one by ear. I include that on there because I do think it's important to involve the larger agency wherever possible in providing and helping out that next level of care. EAP, I don't know if you guys have EAPs. You have an EAP? Yeah, we've got EAPs locally here. I know EAPs sometimes get a bad rap. And for me, an EAP is really best designed to be a bridge. EAP can say, let's talk about this, and we'll get you to that next level of care. That's really where they function best, and they really actually do that pretty well. They're not meant for long-term psychotherapy. They're not meant for this stuff, but they're great to kind of consult with and say, hey, I'm having this issue. A lot of them will do legal stuff and other things. They can actually kind of help out in a broader sense than we think. So I like to include them as well. If there is one thing that has been good about the whole COVID thing is that we finally sort of, as mental health professionals, sort of broke the state rule about telehealth. And we can now, I as a licensed psychologist in New York, can see anybody in New York, anywhere. and do. My private practice, I do 2 days a week. It's fully telehealth. I got people from the North Country. I got somebody out west. We got people from all over. So what we're trying to do, and I'm involved in a group that's trying to come up with a statewide list of providers that are familiar with first responders, corrections, emergency services, all those kinds of folks. And so that you could say, because I know there's a lot of people like, I don't want to go in somebody in Albany. Like, I live here. Like, I don't want anybody to know. And we get that. There's a lot of reluctance. So you could just go get on telehealth to somebody in, again, Syracuse, Rochester. And we know now, because we've been doing research on this, COVID really spurred a lot of this research, but the VA's been doing it for about a decade. Telehealth seems to be just as effective as in-person therapy. So we really worried that people wouldn't connect well across the screen, but it turns out that in most cases it works just as well. So I can feel safe in saying, listen, if you, for whatever reason, there's nobody where you live, you've tried a couple of people in your area, you don't like them, or you don't have anybody that you can go and find somebody somewhere else in the state. Can't cross state lines just yet because licensure is state-based, but hopefully we'll be fixing that. So there'll be even broader groups of people that are available that you can connect with, right? So what to look for? I'm going to give you my admittedly biased advice on this. And this is advice I would give family members, close friends, about what to do if they're looking for somebody. And this is for both you as an individual, people you know, and even as agencies, what to start to look for. Again, I will, wherever possible, I will acknowledge my personal bias in this because I have them. So for depression, for me, depression is sort of the common cold of mental health, meaning that if you are a licensed mental health professional, you should be able to treat depression. Right? Every licensed mental health professional should be able to do a good job. So for me, I happen to do cognitive behavior therapy. It's an effective treatment for depression. If you want to look for that, that's great. But since a lot of people can do it, look for someone you connect with. If the person says, I tried that for a couple of weeks, that person sucked, I didn't like them, go, there's plenty of other people out there for this. You can find somebody that you can fit with. It might take a couple tries, but there's somebody out there that is in the style that you like, that understands you, kind of gets that world, and that's what we really want to look for, that you kind of connect with that person. So this is the easiest one to do if a person is struggling with a really kind of low mood or kind of just general anxiety, that you can find somebody pretty easily. Substance use and abuse, I would say that the standard that we see in America is AA-based models, these kind of abstinence models, 12-step models. They're everywhere. They're in every town in America, and they're all online. And if you don't want to go to the local one because somebody is there that you would know, I've got a patient that goes to their regular AA meetings. They go in Connecticut. They go virtually because they had reasons they didn't want to be seen in their town. And they said, well, they found some people, and that's what they do. Every week they go to their meeting in Connecticut. And that's totally okay. There are some other models out there, just so you know. There's some non-AA models. They're harder to find, but some people don't like the whole 12-step approach. There are some alternate models. There's actually some non-abstinence models, which is a subset of people who are problem drinkers can learn to drink non-problematically. They actually become social drinkers, if you will. Not everybody, but there's even some models for that, out there. So just point this out. The one that you'll easily find is kind of these abstinence 12-step AA models, but just for somebody that just doesn't work for them, with a little bit of looking, you can find some of these other models that might be a better fit for you or for whoever. So PTSD is a little bit different from depression. I think that not every therapist is trained up really well to do PTSD work, to do heavy kind of trauma work. You really want to look for somebody that knows what they're doing with that. That is not kind of the common cold. It is something that the work can be challenging. What I would say that you would ask for is ask that therapist or ask that person, whoever that is, if they do an exposure-based model of treatment. Right? So they'll know what you're saying when you say that. They'll know what you mean. Two of the versions that are approved by the VA. So you see this. Any psychologist that's been trained by the VA will typically have these kind of, will more often than not have these kind of trainings. Prolonged exposure therapy is one of them, and another one called cognitive processing therapy, which is also an exposure-based therapy. There's some other models that are actually out now. But they're also exposure-based. So if you say, I want someone that does some exposure kind of work, I will say that as someone that does this kind of work, it can be challenging for it to do. You have to talk about the traumatic event. People don't like that. There are ways we're figuring out to make it easier for people to do. and some of the newer models do that, but they're all kind of under this umbrella of exposure-based treatments. You'll also sometimes hear about something called EMDR, which stands for eye movement desensitization and reprocessing. I think of it as another type of exposure therapy. The EMDR people don't typically call themselves exposure therapists, but it has been shown to be effective. And I've seen, for whatever reason, a lot of first responder folks I see this a lot being recommended, and it does have some evidence for its use. But again, for depression, I would say just find somebody you click with. You really want to find somebody that has the skills and the training to do this kind of work if you really want to work with PTSD. It's these kind of interventions that have been shown to be really effective in treatment of PTSD. Again, 12 to 16 weeks, and at least in some of the newer models, as short as 5 or 6 weeks, can see significant improvements in symptoms, even for somebody who's had it for a long time. Even in a person who's had it based on multi-traumas, right? Like it's an accumulation of these many traumas. The stuff still works. For suicidality, the new, do people know 988? No? I was like, this is like, yeah, you guys know, right? So as of June 1st, it was June 1st? Was it this weekend? 988 is now the National Suicide Prevention Helpline Connection. We're really trying to publicize that, right? Because it is the 800 number will still work. That is the old number that you probably see those posters up and things like that. It's basically, they've just made it easier to reach. 24/7, and they will connect you. They can help do a crisis assessment. They'll do an intervention. They even have access to sometimes to help find local people. But this is something I say, now that you know this, it's 3 o'clock in the morning, you got somebody who looks like they're not doing well, you can pick up your own phone, pick up their phone, call 988 and get connected right away. It's the one I used to tell people, everybody put that 800 number in your phone, have it handy. I would make everybody that I worked with have that number handy. And now I say now it's 988. It's much, much easier. But that is a resource that you can have. And everybody can have that. It's free 24/7. It is not first responder, whatever, emergency services, whatever you want to call it. It's not that specific. It is for everybody. So this is something that, if you out in your personal life and a friend or family member has an issue, you can use the same number, right? EAP is also, sometimes they have crisis lines and can do some of that same work as well and can refer you to local resources. And every county in New York has usually through the county health department, has a crisis team. And we've got through CDPC, we have our crisis that a lot of you guys know. We have a crisis line, and then the new program through the county that's got also for mental health folks out in the field. But every county has this available to be able to do emergency assessment and, if necessary, transport. All right, wrapping up, almost done with that here. There is a post-training evaluation that you guys will all get. We'll send it out. Please do that. This has been kind of a work in progress. Like we've gone through a couple iterations of this. I'm really interested in some of you guys saying I really like that part of it. Maybe even do more of that. Parts of it you're like, not so much, didn't love that part. I really want to hear all that feedback because we're really trying to kind of iterate this and go through cycles of it to make it better and be more relevant. Trying to fit a lot of stuff into like an hour and X minutes, and it's really hard to do. So I really want to get, again, the biggest kind of bang for the buck stuff. So please give me feedback, good feedback, not so good feedback. I want to hear it all. So again, sort of as we're wrapping up, like I said, these issues are always going to be with us. They're always going to be with us as a society, but particularly in what we do, we are always going to be at elevated risk. It is built into the job, and there is no way around it, right? We're going to be at elevated risk, but we can minimize that risk, right? We can do things directly ourselves and with each other that not only minimizes our risk for developing these issues, but maximizes the possibility that other people are going to get the help they need. So that whole first half where I said like all the sort of the bad stuff, the second half is there really is hope with this. We have effective treatments, we have effective procedures that work. We know that they decrease our risk for ourselves and for other people. We're just going to start putting them into place. And for me, I'm a bang for the buck guy when it comes to this stuff. I don't want to give you 73,000 things to do that you'll forget. I just start focusing on one or two of these things. Like again, physical stuff, maybe you focus on getting sleep first, and then you focus on other stuff. Maybe you focus on, a couple interventions of making sure you do some social things every week to kind of feel connected to your social circles. Don't get hung up feeling that this is a part-time job of 20 hours a week. You got to do a bunch of stuff, right? This is, focus on those big things, the few things that have a big impact. And that's really what I wanted to kind of give you guys, is the stuff that is most reliably shown to be effective, that is relatively easy to do, and again, is across the board, works pretty well. Again, the idea is that we're trying to get 75% of people to look at this. Why? Because we want this to be a sustainable change, right? We want this to be something that gets into to departments and agencies and becomes something that 10 years from now, it's changed the department culture, right? That everybody's kind of doing this kind of stuff. That's what we're really hoping for. And so by being examples, by doing this stuff, again, whether that's saying, hey, you're doing okay, or talking about making sure that you're keeping engaged in your life, we really want to start to change department culture is to make this meaningful difference that's going to last. And that is all I have. There's a very small font email to reach me. I'm at the University of Albany. You can probably find me through the psychology department there. I'll leave that up for a minute, but that's what I've got. Do I have any questions or anything? Comments? Whatever? This is already longer than we expected kind of thing? Like, please get me out of here. Well, again, like I said, please give me feedback on that. If it was great, that's great. If there's something like, could we hear a little bit more of that? I'd also like to hear that. Like anything to really help us kind of, navigate, trying to maximize that information in like a little over an hour.